So type 1 diabetes is, of course, a very complex disease where we have to adjust the insulin dose for the exercise, for the meal intake, and want to strive for the best possible glycemic control. And in the past, historically, and in some countries still at present, we perform finger prick monitoring. But that gives us only points in time where we can see glucose values, but we do not have like a consistent signal. So we miss out a lot in between. So what we have seen when introducing CGM, we can reduce if people are properly trained. So it's not only just putting the sensor and off you go, but really instruct people how to use it. But then we can see improvement in glycemic control and also reductions in hypoglycemia. Early type 1 diabetes can be the phase where you still have normal glycemia, but positive autoantibodies. And it's crucial to really find the correct point in time when to initiate either preventive therapy or at least insulin therapy to avoid acute complications. So with CGM, we have a tool in hand that can help to diagnose and that can help to assess glucose values without having a lot of burden to the people living with diabetes, because you don't need to do an OGTT maybe, you don't need to do finger prick monitoring. The downsides of CGM can be the inaccuracies, so maybe they are under-representing the true values of glycemia because some glucose detecting devices are reading lower than the actual glucose value would be in blood. And another problem, of course, is availability and data interpretation. So people really need to be well trained in how to use the device. We have seen that the majority of people without diabetes would have the glucose values below 140 milligrams in the majority of time. So if you see trends over 140, that can be a hint that the person is developing diabetes. But really importantly, especially if we think on a global perspective, is the price and the availability of these systems. So what we have seen in both type 1 diabetes and also insulin-treated type 2 diabetes, that CGM on the one hand side improves quality of life. That's for sure. That's one of the parameters that are unfortunately not seen by the payers. So they do not really relate on these parameters yet. On the contrast, journals also want to hear about quality of life. So that's a bit, and also projects want to really assess quality of life. So that's for me a bit kind of the balancing act. What parameters do we assess and what is impactful also for getting reimbursement done? For reimbursement strategies, we need to have hard facts. And these are unfortunately only metrics of glucose control, meaning hypoglycemia, HbA1c, time in range. And these parameters, of course, all improve when CGM is appropriately used. We also see tendencies that early stages of type 2 diabetes might have some benefits, that maybe also people on other forms of diabetes have benefits. But the strongest evidence we have for type 1 diabetes on insulin and type 2 diabetes on insulin. So if you need to prioritize, of course, you would go down the line from insulin therapy people to people on oral agents to people who are on conventional therapies such as exercise and nutritional support management. But of course, if the cost would be at a reasonable level and people could afford it, I think the majority of people with diabetes would benefit from having more insights into their data. So you can see, for example, people with very high HbA1c where you are wondering how much lifestyle can have an impact on. And then you see that you provide them insights into their glucose data on a holistic 24/7 basis. They can really adjust their life. They can see what impact this individual meal has, can maybe go for smaller portions for meals with lower glycemic index. So I think there is also room for CGM in other forms of type 2 diabetes. Again, the big challenge at present is the reimbursement.